Welcome, everybody, to our program today, Understanding the Challenges of Universal Biomarker Testing, a regional pilot for non-small cell lung cancer. I'm Dave Bjork. I'm a lung cancer survivor. I'm also a senior vice president at Grit Health. And people who know me know that I am very passionate about biomarker testing and access to care. And so this initiative is really personal for me, and it's really important to me. So we use the healthcare system in diverse healthcare system in North Carolina as a model. We spoke to patients and caregivers and healthcare providers to learn more about persistent challenges in biomarker testing, access, and logistics. So we welcome to this conversation today between healthcare providers and patients regarding the importance of collaboration, best practice, and how lived experiences, particularly in underserved communities, drives important patient outcomes. And so without further ado, I'd like to introduce my friend and collaborator, Richard O'Hara from EMD Serrano. Richard?
All right. Thank you, Dave. I appreciate the opportunity to be here, and I want to welcome everybody for being here. I also want to be transparent at the outset and say that I work for a pharmaceutical company which makes a targeted therapy for a subset of non-small cell lung cancer. And I want to promise you, though, that we are not here today to promote a medication or a company. We're here to discuss and learn to try and help patients and their healthcare team make the best choice possible in deciding their individual treatments for non-small cell. And to do that, it's my belief that we need as much quality information up front as can be gathered. Now, we've come a long way in the treatment of non-small cell lung cancer because it wasn't all that long ago that radiation or chemotherapy in one form or another were really the only options. It's been only about 11 years since the first specific therapy for lung cancer patients with an EGFR mutation was FDA approved for patients in the front line. Since then, there's been an explosion in the discovery of gene alterations that can act as drivers of non-small cell, and specific therapies for each individual genetic alteration have been rapidly brought to the clinic. Within just the last 5 years, national guidelines have been updated to add 6 new genetic alterations that are recognized to act as drivers of lung cancer, and all of these have one or more associated specific therapies, bringing the total number of actionable biomarkers in patients with non-small cell to 11. We've never had more treatment options for patients with non-small cell than we do today, and it shows in the patient outcomes. Patients with lung cancer are living longer, healthier lives than at any time in history. Yet, I think we have more to do. As a lung cancer community, we can do a better job at getting those advanced therapy options to patients in need. One key point in doing that is to try and establish a broad-based testing paradigm for biomarkers. As I said, there are now 10 classes of genetic alterations with one or more specific targeted therapy options. Another marker, PD-L1 expression on the tumor cell surface, also provides an actionable target. So when physicians are faced with 11 possible targets, how do they choose? How do we decide which therapy is appropriate for each individual patient? In my opinion, the answer is a broad-based screen of each patient to understand which genetic alteration is driving that patient's individual cancer. We've made a lot of progress in the last decade regarding testing for biomarkers in non-small cell. And while testing rates at diagnosis prior to initiation of treatment are on the rise, there's substantial room for improvement. A relatively recent study with a nationwide oncology group practice organization revealed that while there'd been a steady increase in the number of patients being tested at diagnosis prior to therapy, at least 4 out of 10 patients in that organization weren't tested before treatment began. And another study demonstrated that this gap in testing is particularly apparent in underserved populations, which may lack access to modern healthcare. So we celebrate the advances in testing and the resultant benefits to patients, but we have to find ways to ensure the best in healthcare is available for all lung cancer patients. It's often said that a rising tide lifts all boats, and that can be true. In this case, the rising tide of advances in testing leading to targeted therapies can lift lung cancer patients to new levels of treatment outcomes. But there's a corollary to the rising tide metaphor. You have to have a boat. If you don't have access to biomarker testing, you can't be raised by advances in targeted therapies. And at best, you're treading water. So in an effort to begin to address this along with our partners at Grit Health, we wanted to learn more about the challenges and barriers in getting patients tested and therefore to the best treatment. We chose the North Carolina region, as Dave said, because as a testing ground. And the reason is fairly straightforward. North Carolina is representative of many areas in the country. It's home to world-class academic and community medical centers, which can offer the best in U.S. healthcare. It also, like many other parts of the country, has people who have trouble accessing that healthcare, those underserved populations who, by economic or geographic circumstances, have limited access to the healthcare services that could directly impact their outcomes. I want to thank you all for coming today, and I hope you'll benefit from what we've been able to learn thus far and in our efforts to put a human face on the successes and challenges in universal biomarker testing. We've tried to bring you a representation of providers and patients who, by discussing their individual challenges and successes, can engender further discussion in this area of critical need. And we want to hear your voice too. Please make use of the chat function to tell us your thoughts and experiences and possible improvements as we spend the next hour together. And with that, I'll turn it back to Dave.
Thank you, Richard. And so now, without further ado, I am honored to introduce our amazing North Carolina panelists today. And if you guys, Terry, I'll start with you. If you could just give us a real brief 1 or 2 minute intro about yourself, and then we'll get more into the lived experience in the next part.
Okay, for sure. My name is Terry Conneran. I live in Charlotte, North Carolina. I'm a 7.5-year lung cancer survivor of KRAS. And briefly, what happened was took me 3 years to find out what was driving my cancer, and that it is KRAS. But currently have no evidence of disease after 5 recurrences. So happy to be here and share in this important initiative.
Awesome. Great to see you, Terry. And now, Dr. Patu, would you like to say hello?
Hello, everyone. Yeah, so as you mentioned, my name is Samir Batu. So I'm currently doing thoracic oncology here at ECU Greenville. I'm an associate professor. I just came in about a year ago. Prior to that, I was with Mayo Clinic Health System for about 7 years. I did train in New York State in Buffalo for my residency, and then for my fellowship, I went to SUNY Downstate and Sloan in New York City. And currently, as I said, I do thoracic oncology, and molecular testing is, something which is very close what I do every day, basically. And besides that, I am also associate program director for our fellowship program.
Awesome. Thank you. Welcome. Great to see you. And now, Dr. J. Ram.
Yeah, so I'm a community oncologist with Southeastern Medical Oncology. We've been here in Jacksonville now since 2011, so I've been practicing here for about 14 years. We treat all cancers, but we do treat, let's say lung cancer is probably the second most frequently treated cancer that we're treating now. And I would agree with Dr. Batu in the sense that, we are testing biomarker testing a lot. So we're kind of following, although we do experience some challenges with that.
Awesome. Well, again, welcome. It's great to see you as well. So I'm really glad that we have you all together today. And I'd like to now kind of move into, we talk about lived experience and how critical that is in creating community, improving patient outcomes, and kind of humanizing the healthcare system. Terry, I'd like to start with you. And it's specific to biomarkers. Did you feel informed about biomarkers, and why was that important?
No, I wasn't informed about biomarkers. Let me kind of walk you through what happened when I was diagnosed with lung cancer. And I wasn't being part of a regular screening or anything. I had a high school, college smoking experience, and so it wasn't like I had was ongoing with smoking and that sort of thing. So the diagnosis came, and from the diagnosis, they automatically did biomarker testing. I was being seen at a community center. And it was sent out just as a matter of course, because I initially presented as I was presumably stage 4 lung cancer. And when that got sent out, the test results came back. And although I didn't realize that's what was changing my treatment journey, and they were making decisions based on that, I didn't get a copy of the report. And I didn't realize it. So what happened was I was diagnosed. I went through my treatment, just followed through and just did what the doctor told me. I was actually stage 3, went through chemo and surgery, and started getting my regular scans. And at regular scans, when I was just kind of preparing to see and go through, reconcile what I'd been through with cancer diagnosis, got involved with lung cancer support groups and started hearing about these biomarkers, and really felt kind of uninformed compared to a lot of the other people in our groups. And hearing these EGFR and ALK and what have you really pushed my doctor, what's my biomarker, so that I could also connect with those people and understand what it was that was driving my cancer so I could get connected with others like me. And my doctor told me I didn't have any biomarkers, okay? Well, that wasn't true. They had done the testing, and I was pushing her, asking, didn't get the copy of the report, didn't know I didn't have a copy of the report. And after 2 recurrences, I went out for a second opinion at a bigger center. And that's where I learned that on the initial 2 reports done, and when they reran the report, I was KRAS and KRAS G12D. And hearing that I had KRAS, although it didn't change my treatment, it changed everything for me as a patient, because it gave me enough information to be able to go out and look for information, to become more knowledgeable, much more empowered and informed around my cancer diagnosis, and what to do, what not to do, or what just kind of, it named this devil that I was fighting in my body that I'd been fighting all along. And that was very empowering to me, realizing that this thing was undruggable and that KRAS is also in, besides lung, it's in colorectal and pancreatic cancers, appendiceals, and what have you. I ended up starting the KRAS Kickers because there wasn't a group of people to come together around this. And so the KRAS Kickers became a patient empowerment group through Facebook and virtual, because in 2020 we had COVID, and so we did everything virtually back then. And so now we're continuing that. So now we're like in 110 different countries worldwide, and sharing that information around the clinical trials and what we need to know and understand. But it still boils down to your initial question: what am I? What are we doing? And how a doctor can make a most strategic decision for what's next. And to me, it really provided me as a patient the information to give me authority to turn away from the snake oil that they're trying to sell me online because I've got lung cancer. And so it gave me enough of that information. So although it wasn't treatable unto itself, that sense of identity empowerment was incredibly powerful for me as a patient, and that knowledge for what's next.
Yeah, it was. I know. So it was less about the treatment, changing the course of the treatment, but it was personal for you. And then once I've heard you say, you want to know, what it is that they're looking for, or just know so you can be connected, right? So did you feel supported by the healthcare team throughout? Like, it's sort of at the beginning, but then you got the second opinion. Did the second opinion change?
Okay, well, to be very transparent, okay, I mean, I have to speak my truth, okay, and when I was going through it, I felt very supported. I didn't feel like I was getting the shaft in any way, shape, or form. But afterwards, when you have like the beauty and the time to kind of look back with 2020 hindsight and see the information was out there, I was asking the questions, I wasn't getting the information, that made me feel like a lot more distrusting in my healthcare professional. I had to change healthcare professionals, because if I wasn't being provided the information I was asking for, what else am I not learning about? Okay, and I was seeing a general oncologist. I was not seeing a thoracic oncologist, and so I lost my level of trust with them. And I think that once you kind of violate that, you just kind of can't get that back as a patient. You all know that as a patient, you're walking in, it doesn't matter what the diagnosis is. I'm trusting a total stranger with my life to make changing decisions by what chemicals you're putting in my body, whether you're burning me with radiation, whatever it is that you're doing, cutting me open. I'm trusting a total stranger. And so when I found out that that trust was violated, I had to change healthcare systems. So afterwards, I didn't. Wonderful doctor. I have no disease right now, so no complaint.
Yeah.
But it really very much lost that sense of, you know, that this DNA that my body is fighting against, this horrible little mutation, you know, I didn't know what it was. And that piece of information was very disappointing not to have.
Yeah, and I know you've mentioned it. I've heard you say, it's not about having a bad doctor. It's just really getting the information, so you could feel that connection. I think that really is an important point, Terry. And so I'd like to ask Dr. Jairam, how do you approach conversations about biomarkers with your patients and their families?
So, um, as we kind of like talk about starting to talk about the conversation about cancer in general, we always start with kind of a big view, right, of things on kind of what the stage is of the cancer, what treatment options are available. Generally, I start the conversation saying that lung cancer is driven now kind of by all of those biomarkers. And what I tell everybody is that we have tested for those biomarkers and we're kind of hoping to see that there is either a treatment available now or a treatment available later for them. But we do have to keep readdressing that kind of biomarker kind of crusade, so to speak, almost every few months because things are changing so often. So we try and readdress that. Now, I'd say this one thing that would be different for a lot of my patients. I think in like for example, Terry in the Charlotte area, I would say, and this is true for when I've practiced in larger, bigger cities that a lot of people are at least you have a good level of education to be able to even begin to ask these questions. I'd say probably at least 40 to 50% of my patients, unfortunately, don't have that level to even be able to open their mind to understand the testing. So it does require several months of teaching about lung cancer after they've already gone through the treatment for them to start understanding and capturing what sort of implications biomarker testing has. So that's kind of one of the barriers that I have with being able to discuss, because we have so much time to discuss with each patient visit. But like just the explanation of why someone has lung cancer, what the stage is, and what does stage mean for a lot of my patients, that's what they can comprehend at this point. So that's one of those things. That's a little bit of a barrier, but I think it's changing. Um, I think initially there was some benefit to some of the ads that you see on TV with that, when PD-L1 drugs first came out. But I feel like that has kind of gone away and it's actually become a barrier too, because now like all these things are coming about and then you see even and now KRAS has a drug. And so you see these things and then now I'm getting where patients don't even want to touch the drugs because the side effects are upfront and almost 70% of the ad now, I think by regulation, which is good. But now it's just an interesting thing on how information is gotten. I do agree with Terry in the sense that it's super important to get good information because there is so much snake oil out there. I just didn't realize how much. I mean, it's there because I mean, of course, FDA came about because of that, because all the drugs had opium in it, right? That's why people used to like all the Dr. J's, this or that. But that stuff is still out there. It's so amazing how scary that stuff is. And I still get questions about that too. So I guess those are some of the barriers that I see, but it's something we keep addressing
Yeah.
throughout the conversations.
And I think that's another important point, Dr. J, is that I feel like we're all just one diagnosis away from like, not expecting to hear a diagnosis that you have lung cancer because we know anybody with lungs can get lung cancer. So, that emotional part is interesting to hear. How about, being in a rural setting, how does that kind of change conversations or additional barriers that you see based on your patient population?
So one problem that we have is a lack of really all specialties, but primary care is one of the big specialties that's lacking everywhere. But definitely amplified in smaller rural regional areas. So when patients are coming to us, we find that they are so advanced, so we would love to be able to be not part of that 40% who are starting treatments before biomarker testing is back. But many times I don't have that possibility because they don't have, 2 to 4 weeks to wait many times. You're kind of in a window where you're treating their stage 4 cancer. And if you're not going to be able to start that treatment, there is a good chance that you're not going to be able to walk them off that cliff. So that's a tough one. The other tough part for me would be just with biopsies themselves, because we don't have a group of interventional pulmonologists who are willing to take chances to take multiple biopsies. We also don't have, we do have interventional radiology, but not as an aggressive as, say, in a tertiary care setting. So we get one shot at these tissue testing, and sometimes we don't get enough tissue. So that's tough. And so we go back for rebiopsy if we can, but there is that possibility that we don't get enough tissue for biopsy. So both of those are major barriers for me. I think the only way to benefit that barrier would be to forcibly make people move into our area and set up practice, which would be great if you guys could do that. Transplant people from your areas here, that'd be great. That would help me a
Well,
lot.
it's
But
a really,
that's kind of one of those things that's out there.
yeah, that's a really good point because I was treated at a major academic center in Boston. They have a whole thoracic team, they have a pulmonary nodule clinic, they have so many resources that are maybe not available in more rural settings. So, thank you for sharing that. And Dr. Batu, how do you approach conversations about biomarkers with your patients?
So again, as the reason where, you're talking about it, because biomarker testing is so important for our patients, as Richard mentioned at the beginning, how biomarker testing and targetable, treatments have revolutionized the treatment of lung cancer. And that's why it's very, very important to discuss that with our patients. So in order for my discussion with the patient, it depends on who I'm talking to. Who is my patient? What's their socioeconomic status? So it's not only my personal experience. There was actually a study done on that based on reported the conversation between the oncologist and the patients. I think there were about 60 patients that they included in that study. And after the conversation, about 50% of the patients didn't even understand what the oncologist was saying. And the things like, simple things like mutation, 50% of the patients didn't even understand that. So, from those studies, it's very important for us. It makes us understand that every patient is not the same. Conversation has to be tailored up depending upon that patient. So one of the important factors that came out of that study, that those who are from higher socioeconomic status, like that there was a salary about 60,000, they understood better. Like 80% of those patients understood better mutations, the driver mutations, the genomics, and all that stuff compared to patients whose salary was less than 60,000. And that's why, even when I have a conversation with a patient, although, a lot of our patients, I'm in a bigger academic center, we have patients who are very, knowledgeable and they've already done their homework, but we still get a lot of referrals from the rural communities, right? And we get patients for the second opinion. So we still have to deal with those patients. So that's why I try to make that conversation very simple and basic. Rather than telling them the mutation, I tell them what there's a change in the DNAs. So trying to making them understand why these changes in the DNAs are important, how that is changing as far as the landscape of treatment, how the outcomes are different. And as Richard mentioned, the treatment before, all we had was one chemotherapy or radiation. It was just basically one size fits all. And at that time, our 5-year survival for stage 4 lung cancer was 1%. And now, about a decade and 15 years later, same, without it, like just with the immunotherapy only, It's about 10 to 15%. And in patients who actually have these driver mutations, their 5-year survival is going to 20, even 30%. And we are seeing, we're seeing these patients that actually, we have our patients in the clinic right now who are without any treatment because they've been on treatments for about 2 years and then being in complete remission and being without the treatment. And we have turned some patients are on the treatments for about 5 years. So for some patients, it has become chronic. That's why this conversation with the patient, again, I don't think that this conversation, yes, the main theme of the conversation is the same. Yes, there is this testing. We have the drugs that will target and their outcomes can be better. But in order to connect with the patient and getting that message through, I think we have to definitely look at the patient, who are we talking to, and getting to that level and making them understand what this means.
Yeah, so we can't make just the assumption that you work at a larger
Right.
cancer institution that it's still challenges. There's still, I've heard from both of you some of the challenges of whether it's a socioeconomic economic status or the rural population or people coming in late,
Absolutely.
and they're really sick. Those are really important. And Terry, I saw you nodding your head quite a bit. What resonated with from what you've heard so far?
You know, I like to think that I may not be the sharpest tool, but I can be sharpened up. And so when you're kind of just going through that whole cancer journey, you're focused on one thing, staying alive. And, had my doctor suggested something other than surgery or chemo right out of the gate, I would be like, do I need a different doctor? Because I didn't understand what all was going on. I didn't have the gift of time, and I didn't realize how important the biomarkers and is much more important today than it was 7 years ago during diagnosis for me. But I think that that's a crucial point of it. And the other thing that kind of resonated with me is, I was one of the lucky ones that had the testing. And here I was, I'm a white middle-class woman that had the testing. I'm asking the questions, I'm not getting the information that I was requesting. And let me tell you, snake oil starts looking good. And the reason it starts looking good is because you don't have enough information to drill down around whatever it is, because you all know that there's a huge difference. It's not just lung cancer is one disease, whether it's small cell, adenocarcinoma, squamous, how far metastasized it is, EGFR is different than ALK and what have you. You all know that, but as a patient, till we have like enough of a snippet of information to go looking, it makes it so tempting to start going down that path. And so I applaud you both for asking the questions with your patients and being open-minded, because I know that it's happening. And I can't even say I don't blame people and I don't blame the doctors, but there's a way that education can kind of come up. And to kind of circle back, I was too busy trying to survive what I was going through from day to day to be able to kind of grasp the whole genetics and genomics of the whole mess. And so I appreciate that part of it. And, I think that we need to do better with it across all channels.
Yeah, thanks, Terry. Yeah, and I'm really interested in kind of even maybe pulling out even more from both you doctors about you've mentioned a couple of the challenges. Are there any other challenges that you typically face, particularly if we're thinking about patients that are from underserved communities that are seeing you?
So again, when patients come for the second opinions or come from the, obviously the rural areas, especially if they already have testing. So one of the things that we usually see that the testing wasn't more broad-based, it was very limited. So a lot of times we have to, basically request more testing. I think that's one of the common challenges that we see, although the things are changing considerably. Again, I usually talk about the studies. I talk about the numbers because I look at these things. So that, if we look at, there was a study done that looked at has the things improved? Yes, luckily things have improved. So prior, we used to do about testing, but we were doing not that great. We're like testing only 50, 60% of patients. It was also very limited. Now the things have gone up to even 80%. I'm talking about only the lung cancer patients. Same thing with the other cancers like colorectal cancer. The same study looked at that improved from 40 to 60%. So we are definitely doing better, but we still, have these challenges that we have to deal with a lot. So in our own institution, I think the main challenge, and I think we touched this a little bit, is about tissue still. Despite having here, collaboration with our pulmonary intervention radiology, we still run with this issue sometimes, although it's very limited. We try to work on it so that it is not as bad as it used to be. Because, we have also incorporated what we call doing liquid biopsies right off the base when the patient see our pulmonary colleagues. We haven't been able to do that with our intervention radiology colleagues. So we are also having challenges there. So also the patients who come from outside, they don't have liquid biopsies done, right off the batch, when they actually have high suspicious for cancer and they go for the procedure. And that's what we do, usually the sampling here. This is very, very important for our medical oncologists because, as Dr. Jairam mentioned, that there are patients, they cannot wait for their treatments. They are highly symptomatic. The disease burden is very high. So they don't have those 2 weeks to wait for that testing to come back. So with the liquid biopsy, that's the important thing. So if that sample is done right away, right where the biopsy was done, within a week or 10 days, you will have the basic results. What you need, what you want to do up front. The other thing, that's really helped us in, a lot of times just go ahead with the chemotherapy, knowing that, there isn't any driver mutation in the liquid biopsy. And the concordance rate with the liquids and the tissue is about 80%. If you look at upfront at diagnosis, it's a different story when the patients are recurrent. The concordance rate is only 40%. So that's why, upfront, I feel like liquid biopsy has more role than in the recurrent setting. That's why at recurrent setting, we'd like to have more tissue to get more, testing done because, these pathways can get bypassed. So there are a lot of nuances, a lot of things that we think when we see patients like that. So despite that, I think there are patients here and there, we don't have enough tissue. So we do rely on the liquid biopsies, although we want to rely not much on that. So, but overall, I think we are getting better in testing patients. We are getting better in doing comprehensive testing. And it shows up in the results. It shows our patients are living longer and patients are getting treatment what they need. So one more point I want to add here, especially in setting where the patient is not symptomatic and can wait for 2 weeks. I rarely tell all my colleagues, all my patients, there's no harm in waiting for those 2 weeks because it makes a difference. And again, I talk about the numbers. There was a study actually looked into it. There was a retrospective study that showed those who actually got empirical treatment without waiting for the testing results, their outcome was inferior. So it does make a difference. Of course, there will be situations where we can't wait. In that situation, I just use only chemotherapy. I don't add immunotherapy right away because I know that could be actually harmful if they have
Right.
mutations. So these are some of the important things that we look at when we actually see the patient and decide about the treatment. Again, still, we do have some, challenges that we are dealing with, but we are coming with solutions, day by day.
Yeah, and that I've often shared the story about a personal friend of mine who went in for he was having an nagging cough. He didn't have I had just seen him. He looked perfectly healthy, but he was diagnosed with stage 4 lung cancer and put on chemotherapy. And 24 hours later, he was on a ventilator. And they did get the results back 2 weeks later, and it was EGFR. So he passed away 4 weeks later. So that always hits home with me when I hear those stories about understanding that if you're so symptomatic that maybe you can't wait. But Dr. J, do you have similar experience with the liquid biopsy part of that?
Yeah, so that's one thing that we've changed over probably the last 3 years is that we send liquid at the time of the tissue also. So we do both at the same time. So that's been very helpful to kind of get targeted treatments. Although sometimes I have run into in the past barriers. It's getting better insurance-wise. Insurance was kicking out a liquid biopsy result without a tissue biopsy result in the past. They've gotten better with that though. So that's a good thing. I guess the other barrier that I kind of see with a lot of my patients, two things would be just transportation and kind of daily needs. Many times they're already kind of struggling with that. The financial toxicity of cancer therapies and cancer diagnosis, all that stuff is really tough for patients to deal with. So That's another thing that we kind of we have an organization that's kind of a sister organization to our uh, organization called SCC, or Southeastern Cancer Care. And that organization provides for Eastern North Carolina patients. It doesn't have to be our own clinic, but anybody with cancer, help with, say, gas cards, food cards, rent, utilities, that sort of thing. So that's one thing that we find to be a big need as well.
Yeah, that's super important because I had a community outreach worker, actually in North Carolina, who told me a story about a patient that was non-compliant. I don't like that phrase. I don't like that word, but it was because he was living in his car in a parking lot in Walmart, and so she drove out to give him a gas card so he could get money to put gas in his car. So certainly those are some real life examples too. And back over to you, Terry. You mentioned a little bit earlier, but I still would love to hear your patient perspective of the sense of community and not feeling alone. It's like I've heard you say things like, "Where are my people?"
Mhm.
And you didn't know who your people were before, you found them. But how, just kind of how important is to share your experience with others?
I think it doesn't matter what thing you're going through in your life, whether you have a baby or going through something difficult like cancer, you want to connect with other people that have that same thing as you. And for lung cancer particularly, to me, it felt like there was a sorority rush or something, and nobody rushed me because you'd have these different groups of people that, like, they for good reasons. Small cell is different than EGFR and ALK and whatever, and not knowing that sense of identity and having that so I could connect with other people really was it was a very lonely place. And the last place you want to be when you're in this sort of a battle is alone in that trench, and having that sense of we can't solve your problem, okay? And like KRES kickers, we don't give healthcare advice, we provide information, we're really there for it, but really more than anything, we're there to kind of like let people know that they're not alone in this. And really that we're alongside of you, okay? And you, I don't know if you did this on purpose or not, Dave, but like you're keying me up, okay? Because I'll just climb up on a soapbox about it, okay? Because when you find out that something like KRAS is what's driving this cancer, and you didn't know what it was, and here it is, your body's fighting it, and there's other people out there with the same thing as you. Oh my gosh, that's an empowering moment, okay? And that empowering moment means I want to walk alongside of people with this. And okay, so there it goes. Okay, so, and all right, we have KRES Kicker socks, and the reason we have socks, okay, and this isn't huge self-promotion, this represents how important it is. Patients, like literally, we're the soul, and we're the humble part of this, and we want to have people, doctors, physicians, pharma, other people around us, walking alongside of us, not top down, side by side, and knowing that somebody else is there alongside of you, who's got your back, and you're not going to be alone in this whole survivorship journey. And
Yeah.
better yet, that it's going to have survivorship implications, not just, oh, we're going to go get together and then we're just going to jump off a bridge. Okay, and so I
Yeah.
think that that's where that real hope comes from.
Yeah, for sure. And again, if we bring it back to, biomarker testing, I've heard people say, well, we don't want to give patients false hope. And I'm like, well, my doctor, my doctor friends say we're going to look under every stone, and taking that approach versus, well, like thinking about what if I don't have a biomarker. So what I'd like to kind of again go back to the Dr. J and Dr. Batu, and you hit on something earlier about insurance. So I'm wondering if there's anything that you would kind of talk about some of the recommendations or how we can make everything better, how we make the system better, whether it's from the community side or whether from the academic side. But are there are there insurance issues? Are there perceptions about insurance that confuse patients? I'll start with you, Dr. J.
Um, I think insurance is just a confusing arena for everybody because as soon as you figure it out, you find a interesting way that it decides to throw you something that you haven't seen before. But having said that, I think for all of us kind of in oncology, we usually have pretty big groups of uh, individuals around us that kind of deal only with that. So that's been kind of where we kind of turn to figure out how to get the patients the treatments that they need. Um, but from that standpoint, I think the other portion of the kind of the insurance game that we've looked at, recently is kind of, how to get patients, signed up for coverages when they actually could, when they don't have any coverage, for example, when they have no insurance. So that's a big arena that we've been trying to push recently as well.
And also, curious too, also in your practice, do you have vendor relationships with lab companies that are important, or do you have internal labs that do the biomarker testing?
Yeah, so I do have like we have relationships with lab companies that we're kind of doing most of our biomarker testing in. So and those lab companies in are have been pretty good in terms of allowing the testing to be done and then reported even before you know whether insurance is paying for the testing or not. So that's a good thing. Companies have been pretty good about releasing that information before that's come about. Um, and they have very good patient assistance kind of programs out there. So most of the time, I'm not seeing patients having to pay out of pocket or to have an insurance problem with biomarker testing, at least.
Yeah, that's it. I've always wondered about that, and um, maybe it's my naivete, but I always wonder if there's patients know that there are always ways that they can get biomarkers covered, or is that a real thing? Do you know what I mean? Like you mentioned the patient assistance programs. Is that from the labs that provide
Sure.
that?
So there are, sometimes there is testing that you may do. Like so we're we're all, I'm sure Dr. Batu is doing the same. We're doing wide panels testing for all mutations. And so initially when we started doing the wider panels, there was pushback from Medicare in terms of whether that wider panel was necessary when we only had certain biomarkers that you can actually target. That's gotten better. In the last 2 years, those wider panels have been kind of widely approved by, because they use Medicare as a model. All the private insurers use Medicare as the model. So once Medicare allows it, so once Medicare kind of agreed several years ago that overall biomarker, like um, um, a large panel of testing is okay to do, general panel, then it's been easier to get everything approved for patients. Yeah.
And you think that's happening more?
Yeah, I think for most people, it is the wider biomarker testing is being done by most, even community oncologists like myself. Most people have kind of moved over to that sort of testing, I think.
Yeah. And Dr. Patu, from your perspective at your institution, any other comments about these decreasing turnaround time for results or perceptions about insurance or any other kinds of recommendations, I guess, from your perspective?
So yeah, so we'll see. We deal with such situations here in our setting too. No doubt about it. As Dr. Jairam mentioned, that very nicely, that's very confusing. But at the same time, it's a reality. How our health system is based on insurance, and over the period of time, we have realized that although there may be issues at times, but there are ways to help the patients because all our goal is to help the patients. get them what they need, whether it's a biomarker testing, it's a treatment. So we want the patients to get that treatment. We don't want to have the patient say, hey, I'm sorry, your insurance doesn't cover it, and then you're not going to get this thing done. So no, that's not our attitude. Our attitude is when we have a discussion, don't worry about it, we'll take care of it. And we have a whole team of it. And, as Dr. Jara mentioned that, they work on, there are assistant programs, not only from the insurance companies, from vendors. And, we work closely with the vendors. We obviously have very close relationship with some lab companies where we do most of our testing. So they understand there will be patients where, where the insurance issue may arise, but they don't hold the results at that time. So they still release the results. And then we work on in the background, just trying to get that thing taken care of. So there are ways to do it. And so I must say that, with like pride that so far all, here or when I was in the Mayo Clinic Health System, we never had even a single patient who didn't get the testing that we wanted and didn't get the treatment that we wanted. So yes, there are challenges with it, but there are ways to deal with it. And I think we are getting better in taking care of it, but it's a reality. So this is how our health system is based on, and we got to work along with it and try to make things better for our patients.
Yeah. And Dr. J, again, from the community perspective, how do you feel that is the knowledge base of, of other practitioners, other oncologists who might not just focus on lung cancer, but might see a lung cancer patient, and how do you think it feels like that would be hard for people to keep up on all the different changes that are happening, or to understand all of the different biomarkers, because like you said earlier, it's changing like every month. It feels like it's constantly changing. So what do you think about the general knowledge of other oncologists that are not just focused on lung cancer?
I think it's gotten a lot better in terms of because of the mutational testing that we have to do for all cancers. We're getting better and better about understanding what's out there. But because we have good, strict guidelines in terms of NCCN guidelines, which is our national cancer guidelines that we can kind of go to and click on and understand what's out there, what's available, what's changing. All of us kind of use those guidelines kind of continuously. In the past, we might have had kind of treatment algorithms in our head that we would be able to go after because not a lot changed. But, at this point, every single cancer is continually changing. So nobody really relies on that anymore, on what they remember. So they kind of go back, and all of us are continually reading, I think. That's one thing with oncology that may not be always true with every other medical profession, because sometimes those things don't change as much. But for us, yeah.
Yeah, thank you for that. And Dr. Batu, from your perspective, and you do get second opinions from people in other settings. How do you feel about the knowledge base of what we call community oncologists versus a place like yours?
I agree with completely Dr. Jared with us oncologists. So we always stay abreast of what's going on, in our field, because we know it's a very dynamic field. It's not like other fields. That's what I talk to my fellows all the time. Also, although I like to joke about other disease specialties too, but obviously I can't do that here. But again, yeah, I agree with them completely. Most of them are very knowledgeable. The other thing that we have seen over the years, the way the results are now provided to the providers, oncologists. So there's clearly these mutations showing there, which drugs are available, what trials based on. So there's a very comprehensive results now available. It's not just, okay, patient has this mutation, that's it. So that's very, very helpful for the oncologist as well. For our in academics, a setting, we are actually planning to do now actually a molecular tumor board, because as one of my teachers used to say, now the molecular testing has reached to the point that we don't need only zip code. We actually need the actual address to deliver the target. So the same mutations, say, for example, we give example all the time for EGFR mutation. So far, we have 3 mutations now, 19, 21, and we have obviously 20. But there are other variants of EGFR mutation. There are some early phase data where we can actually use targeted agents, which are not FDA approved. That's why these molecular tumor boards come very handy. And of course, we are going to make it in a way that other oncologists, like in our community, because we have other, several community oncologists which work with ECU. So they will have access to that as well. So they can bring the cases into that. So we definitely are, trying to help those oncologists with those variants. But as far as the mutations where there are approved targetable agents, I think I agree with Dr. Jairam. All the oncologists are well versed for what we are dealing with. And again, I must thank our vendors or the labs, the way they are providing the results, comprehensive results with the targetable, drugs clearly mentioned that what we can use. So things are getting better as I more and more learn about these things. Things are definitely much, much better than when we started with molecular testing.
Yeah, I'm really happy to hear that you both talking about comprehensive testing and not making assumptions, based on the patient and say we're just going to do this panel, because I think every patient deserves to have access to that information. Because I think you mentioned that one of the studies, Dr. Batu, about the 40% or 60% of people with access to precision medicine and lung cancer are not getting access to it. And that's not just because they're not getting the test. It's for other reasons, tissue samples. It could be, there's all kinds of, that was a really comprehensive study. I think that's what you mentioned. You may have mentioned that study.
So what I was trying to say, what the testing was before, it was about 40 to 60% in lung cancer patients, and it has improved considerably to 80%. So again, there are about 10, 20% still, which who are not getting tested. And it is even worse in other cancers. So now again, I'm mainly talking about the non-small cell lung cancer. I'm always talking about like colorectal cancers has gone from 20 to 40 to 40 to 60%. So there are about more, gaps in the other cancers. So yeah, as I said, things are improving, but there's still room to improve.
Yeah. And I have to tell you that the practice of oncology is one of the most collaborative uh, uh, places that I've ever been involved with. And I've met so many on my podcast. I've had so many amazing doctors on my program, and they're okay with getting second opinions. They want to do whatever's the best thing for the patient. And that's the last thing I wanted to ask you, Terry, is talk to us about feeling empowered to seek a second opinion.
Wow, getting that second opinion or even knowing that it's something that's okay to do is really hard coming in, because nobody kind of like you don't have like medical education as a kid growing up in like junior high or high school that says, hey, it's okay to do something like get a second opinion. And as I said earlier, like the doctor's got all this vulnerability, and I'm trusting them. I don't want to make you mad. I don't want you to give up on me before I give up on me. And if getting a second opinion is going to make you mad, I'm really hesitant to do it. So I think that, when you encourage us as my physician to go and get a second opinion, it's very empowering. And it says, it's okay, we're all on the same team. But it also says that you're being intentional about my survival. You're being strategic, right? And if I've learned nothing else across between biomarkers and testing and second opinions through the whole thing, it's survival of the strategic. That's important, and that takes a teamwork effort. Kind of like to keep back on the thing that you were talking about earlier, as far as like the actual biomarker testing. As a patient, this coming in, and you're naive to the situation, right? I'm no idea what's going on. All a doctor has to say to me is, I'm not sure if the insurance is going to cover this, and I've already been like dismissed. And it's really important to say, hey, well, let's give it a shot. Let's see if we can get this covered. Most of the time we can get it done, and kind of like walk us through that, because otherwise it's like, wow, now you're seeing the dollars and cents, and it's like I'm dying, and now it's like the financial toxicity is already hitting my shoulders before it's actually become a problem. So I think that that's really an important consideration. Beyond that, but yeah, just encourage us, right? We're trying to do it. We're trusting you. So you saying it's okay really makes it okay.
Yeah, I love that. And I'm sure that our two doctors would agree 100%. So as we begin to wrap up here, I'd just like to know from any last final thoughts. I'll start with you, Dr. J.
No, thank you for doing this. This is really nice to talk with everybody, get everybody's different experiences. That's very beneficial to me.
Awesome. We appreciate that. Dr. Batu?
Yeah, again, thank you so much for doing it. And again, before obviously we arranged this meeting, I already mentioned said that like how passionate I'm about this thing because it's helping our patients. It's helping our patients to live longer. That's what is basically, our goal as oncologists. And this is really helping us. And, platforms like this, it is really, helping not only the other providers, patients, anyone who is involved in the care of the cancer. Really thank you for, arranging this thing.
Well, we appreciate your insights very much. And Terry,
We're not doing this alone. We really are doing this as a team effort,
we're all in this
trying to
together.
get through
Yep.
it, right? And so it's not just the biomarker testing is so important to like the strategy of the decision making, but it's also part of it, of the identity of a patient. So that's really where it is, and that's a lot where that hope comes from. So that's really what I think is important.
Well, I agree. And I thank you for your input as well, Terry. And I wanted to also mention that this, for the panelists and everyone who are here today, this is being recorded and it will be available on demand. So we're hoping to see more and more people get access to this great conversation. But thank you, everybody, thank you, the panelists, for your amazing insights and telling us about North Carolina and things that are happening there. It's a very really important project to me personally. And I want to continue to, I'm sure we'll find ways to continue to collaborate. Terry, we've always joked about that, and you and your husband. And thank you everyone for joining us today. We really appreciate your time, taking time out of your busy day to spend some time with us. And we're just really grateful for all of this. So thank you so much, everyone.